So just want to welcome everyone to our Global Implementation Science Team, or GIST, quarterly seminar. Thanks for joining us today. My name is Marie Bro. I'm an assistant professor in the Department of Health Promotion Behavioral Sciences here at UT Health Houston School of Public Health. And it's my pleasure to welcome Dr. Hassan to speak with us today, somebody I've known for a few years now. Took an implementation science course with back at Yale. So Saria Hassan is an assistant professor at the Emory School of Medicine and Rollins School of Public Health. She's a physician and an implementation scientist with an interest in reducing the inequitable effects of climate change on the health of populations locally and globally. Her work utilizes implementation and system science approaches to address the needs of people living with chronic non-communicable diseases in the setting of climate-induced disasters. Dr. Hassan has an NHLBI funded Career Development Award working with health centers in Puerto Rico and the U.S. Virgin Islands. She's previously worked with the Pan American Health Organization to address disaster preparedness for NCDs in the Caribbean. And she's now translating this work to sub-Saharan Africa, where she's working with colleagues in Mozambique, investigating solutions for preparedness in response to repeated exposure to climate-induced disasters. And then a little bit closer to home in Atlanta, she's PI on a grant looking at the impact of climate change and cumulative environmental exposures on the health of vulnerable communities. So multiple implementation science projects, and also being a small world, sounds like she's also done some work with Dr. McCurdy or their paths have kind of intersected, if not completely crossed, in Tanzania. Dr. Hassan received her MD from Harvard Medical School and completed her Med-Peds training at the Yale School of Medicine. She received her MPH from the London School of Tropical Medicine and Hygiene. And so with that, I'm going to ask you to join me in welcoming Dr. Hassan, who will be discussing addressing chronic disease management in the setting of climate-induced disasters, system science approach. Thank you so much.
Awesome. Thank you so much, Marie, for the kind introduction. Just making sure you can see my slides okay. And so, yeah, awesome. All right. So, you know, this is a relatively small group, so hoping this can be somewhat informal. So please interrupt me and stop me with questions. We don't need to wait till the end here. But really what I'm hoping to do today is talk to you a little bit about what I've been doing, mainly from my NIH K Award work, and thinking about using implementation and system science approaches really to address this need of people living with chronic disease in the setting of disasters. So no disclosures. So here's our outline. Okay, so I see let's wait till the end. Thank you. This is our outline. So, you know, we'll start really just by setting the stage, right, of climate and NCDs and what I call the new double burden, actually, for low and middle income countries. And I'll describe why I say that. Talk about challenges to managing NCDs, specifically in the setting of climate-induced disasters, and how implementation science then fits into that. Then we'll kind of turn to two projects that I've done using implementation and system science approaches. One using non-communicable disease kits in disasters as a regional approach in the Caribbean, and then more at a community, institutional, and individual level using system science approaches to define interventions. So for better or for worse, we do always have to start with making sure we all are on the same page with what we mean by climate change and the difference between climate change and weather. So weather I took a snapshot of this, I think, during what should have been a very cold time in Atlanta, but clearly was not. But climate change is really the changes over years, right? This is not the weather today or tomorrow, changes over years, and looking at temperature, rainfall patterns, really over decades. And what we found, and you can get much more detail and information about this in the series of IPCC reports that have been published, but these are all the climate change effects that we're seeing. So it's temperature rise, temperature extremes, the heat waves. I understand it is still hot in Texas in almost October. More frequent flooding events, these extreme weather events such as hurricanes and cyclones. drought conditions, and then winter storms themselves will hit harder, as also Texas was privy to. And what we also know is that climate change is really caused by these greenhouse gas emissions, right? Which are all a consequence of what we unfortunately have been doing to the planet over many, many decades. But what we realize is that there really is an inequitable effect of climate change. So if we look at this mismatch between the countries that have emitted the most greenhouse gas emissions and the countries that suffer the most burden from climate change. So we have the countries in red, which are the free riders, those who contributed the most in greenhouse gas emissions, but relatively suffer the least from the burden of climate change. And then you have those countries in green, the forced riders, those who have emitted the least in greenhouse gas emissions, but unfortunately suffer the highest burden from climate change. So it's really because of this, and I kind of keep getting asked this question, but it's really because of this that in the context of where I am working and where many of you in a global health setting work, we are working in countries that have historically emitted the least in greenhouse gas emissions. So our conversation is not about mitigation. It's not about how to reduce their greenhouse gas emissions. It's about how we strengthen their adaptation, how they're going to adapt to all of these climate change effects. Not to say that we need to think about how we as a group can reduce our greenhouse gas emissions, but that conversation is for another day. Today, we're really talking about the adaptation. And so what is the impact of climate change on health? And this wheel from the Centers for Disease Control is great in kind of showing us that if we think about the kind of four main consequences of climate change, sea level rise, carbon dioxide, temperature changes, and extreme weather events, there really is a trickling effect of how that impacts health. And regardless of what you do in terms of focus area for health or where you do it, you will see your specific disease or entity or research entity included somewhere in this graphic, really to show us that there's a huge spectrum of ways in which climate change is affecting health. I work a lot in the non-communicable disease space and in the mental health space. I was in Copenhagen for a displacement and the chronic care for displaced individuals around the world. And again, forced migration is a huge consequence of climate change. And they are unfortunately not only experiencing forced migration, but also severe heat and severe cold, right? So take home, there's a myriad of effects, and hopefully all of you can kind of identify where you work and how it also fits into this sphere. So focusing in and again on those true health outcomes that we can measure and that we have data on how climate change is impacting health. You see the spectrum of them here. And again, you'll see non-communicable diseases listed there, which is my primary focus or area of interest. And when we think about exactly how does climate change impact non-communicable diseases? And by non-communicable diseases, I'm talking about the cardiovascular diseases, the respiratory conditions, cancer, diabetes, and I do include mental health because it is a huge part of the impact of climate change on NCDs. And you'll see here things from extreme heat to extreme cold to changes in air quality to drought, flooding, and other extreme weather events, all of which we have information and data to support how they are impacting those non-communicable diseases. So why do I focus on NCDs as a person who works primarily in low middle income areas? And it's because, as many of you know, this is another example of global health inequity. So we know that 80% of premature mortality today is due to NCDs in low and middle income countries. And these same countries have really experienced an epidemiologic shift. So this data is from the Global Burden of Disease Study. So on the top is mortality in the 1990s. In the bottom is mortality in 2019. Blue is our non-communicable diseases. Pink is our infectious diseases. And so you can clearly see if we go from 1990 to 2019, a lot more blue than there is pink. This is the epidemiologic transition. So really what these low middle income countries are seeing is a higher burden of NCDs. And so if we now say that that higher burden of NCDs is worse as a result of climate change, then our mortality in these countries is going to worsen. So as you can see in this cartogram, that if, again, this is the top map is emissions of greenhouse gases. So the skinnier, the less emissions, the more full, the more emissions. And then you look at mortality. and it's the exact flip opposite. So this is really what we're dealing with, and why I think many of us will hopefully start to integrate climate change research and climate change impact on health into our work. And so this is why we call it the new double burden. So higher NCDs, climate change, inequitable consequences of both of those, and so we're going to have worsening global health disparities. And so this is really the premise for which much of the work that I do today is built on. And as Ban Ki-moon put it, climate change affects us all, but it does not affect us all equally. Those who are the least able to cope are being hit the hardest. And so what do we mean by that when we say hit the hardest? In other words, how do we operationalize vulnerability to climate change and health, to the impact of climate change on our health? And so this model from the EPA is a nice way to start thinking about vulnerability of health to climate change as a function of exposure, right? Where you live, it really dictates in many ways the extent to which you're going to be affected by climate change. Your sensitivity, those underlying risk factors that individuals have. We always say in extreme heat, watch out for your elders, watch out for the newborns and the infants, right? So there are always these underlying sensitivities. And then there's that adaptive capacity. This is what I spent the majority of my time looking at. That ability to adapt, that ability to do things within yourself, within your community, to really reduce the impact of climate change on your health. The higher adaptive capacity, the less vulnerability. So this is a nice way to think about how we operationalize vulnerability, and we'll keep coming back to this. So now hopefully we've set the stage. Climate change effects are multiple. We've discussed a variety of them, that it impacts health in a multitude of ways. The vulnerability is a function of exposure, sensitivity, and adaptive capacity. And that climate change, unfortunately, does not affect everyone equally. And that countries contributing the least are really suffering the most due to the impact of climate change on health. And so with that, let's really kind of move and focus really on climate-induced disasters. So we talked more generally and broadly about climate change previously, but my work is really kind of hones in on climate-induced disasters specifically, and talking about climate-induced disasters in the setting of non-communicable diseases. So again, climate-induced disasters, that's our exposure. We're thinking about parts of the world that have higher exposure specifically to these hurricanes. And thinking about people living with chronic disease, who, as we saw, are more sensitive to these impacts of climate change or climate-induced disasters on health. So with now a focus on these two, how can we learn more about this interaction between climate-induced disasters and non-communicable diseases? And so for that, I'll turn now to the Caribbean. The Caribbean, unfortunately, is a part of the world that has been repeatedly hit by climate-induced disasters. In addition to that, actually, the Caribbean has the highest premature mortality due to non-communicable diseases in the Americas. And so unfortunately, this is kind of, again, high exposure, high sensitivity, and a place where we could contribute a lot in trying to thinking about how we increase adaptability or that adaptive capacity. And from the Caribbean and many recent storms, both in the Caribbean and the mainland US, we've started to learn a lot about quantifying the impact of climate-induced disasters on non-communicable diseases. And probably what was most staggering to me was after Hurricane Maria, and realizing that if we look at overall impact of Hurricane Maria on small island developing states, as well as mainland US, at least 30% of those deaths were due to poorly managed non-communicable diseases. And those include cardiovascular disease, respiratory conditions, diabetes, and mental health conditions. From other storms that you see listed here, we have more specific data related to cerebrovascular disease, as well as diabetes and other neurologic problems. I always like to draw out mental health because, as you'll see in all of my work, it keeps coming back to mental health. And so as I'm writing grants now related to mental health, they're like, oh, are you a psychiatrist? Have you always done? I'm like, no, but for better or for worse, my work is all leading me to mental health. And in fact, there is a lot of data to really show that the severe impact that climate-induced disasters have on people with existing mental health disorders, but also acute mental health disorders. And so we then once we saw these numbers, paused to say, what is it about NCDs and the management of NCDs that gets disrupted in the setting of these climate-induced disasters? So this scoping review article, it's now kind of relatively old, from 2020, helped us really kind of hone in on what were the main challenges to managing NCDs in the setting of disasters. And some of these, right, might be intuitive to you. So disrupted healthcare systems, meaning limited access to medication, no access to acute care services, no medical records, communication challenges, mental health challenges, the reliance on ad hoc volunteers, and the access to clean water and access to healthy food, both in terms of having an inadequate quantity as well as an inadequate quality. And I'll just pause there to show these images because I find a lot of global health researchers are in some way working with food and nutrition. And just to say that we now really are kind of shifting another part of our team to really think about food security in the setting of disasters. These were food items in the FEMA packages that were sent to Puerto Rico and the US Virgin Islands after Irma and Maria. So you can imagine if you have diabetes or high blood pressure or heart disease, and this is all the food that you got, that's not going to help manage those chronic conditions. And so what we realized is that we have these challenges, but if we look through this list, it's not like we don't have strategies to address some of these things, maybe in a different context, but there are evidence-based strategies that tell us how to overcome disrupted healthcare systems, maybe not in a cyclone, but maybe in an earthquake or in a flood or in a humanitarian setting in the Middle East. We think about communication challenges and how those might be overcome. Mental health challenges. We have a lot of community health worker-based interventions, for example, that help address acute distress in the setting of a disaster. Again, maybe not in the Caribbean and not in the context of these hurricanes, but still there is some evidence out there. And similarly, the addressing food insecurity in emergencies. How do we take some of the evidence-based strategies that are already out there to address that? So we have a gap, clearly. So we have these challenges, but for some of them at least, we do have some evidence-based strategies in other contexts that we could learn from, and therefore bring to this to devise interventions to address the management of NCDs in climate-induced disasters. And as you all know, in the field of implementation science, that's exactly what we do. We translate evidence into practice and policy. We bring it from one context and think about how it can be useful in another context rather than reinventing the wheel. And many of you have seen this cartoon. The latest research shows that we really should do something with all this research, really honing in on us, trying to better understand that we can move on and rather than reinvent the wheel, see what we can do from what already exists. And these are the tenets of implementation science that I think many of you here are familiar with. But really, I like to always highlight the importance of stakeholder engagement and community engagement, which is really one of the core pillars of what we do in implementation science. And so as we think about how to mind the gap, how to bridge this gap, and again, thinking about those pillars of implementation science, our first goal is always to go to our stakeholders and our community members, learn from their experiences to try to identify the best evidence-based strategies to address the gaps. And in particular for us, what we're looking for are those strategies that are going to strengthen that adaptive capacity, right? So what strategies can help us fill that gap and also strengthen that adaptive capacity? Because if we do that, we then reduce vulnerability to human health, to climate change. And so with that, we'll turn to a couple of examples where we've tried to do exactly that, bridging the gap and strengthening adaptive capacity. So as we think about adaptive capacity, it really can be improved or strengthened at multiple levels. And so we'll first start by looking at an example from a regional approach. So what we realized was that there clearly was that disruption to healthcare system access, disruption to medication access, disruption to that acute care services. And so we decided to think about the non-communicable disease kits, which were extremely successful in providing non-communicable disease care for Syrian refugees in Lebanon and Jordan. And there was a lot of evidence in terms of how we can train individuals to use these kits and really fill the gap for care services in that setting. And so the question was, would it be feasible and acceptable to do something like this for the Caribbean region? And so what we did was, write a grant, but write a grant in partnership with individuals who are clearly, involved and engaged in this on a day-to-day basis to really think about this idea of feasibility and acceptability. And so you see some of our partners listed here and our stakeholders as well. And this was our stakeholder meeting in January 2020, when we had no idea what was going to happen, literally 3 weeks after this meeting, when COVID-19 kind of hit the world. But the purpose of this meeting was to brainstorm who we really needed to talk to. I mean, we're talking Caribbean region, and we don't have a lot of time, and we're trying to really quickly gather feasibility and acceptability data on the use of these COVID-19 kits. And so what we decided to do was do a very small feasibility and acceptability study with the hope that we would do more interviews in the future. And so these were the individuals that we interviewed initially as the COVID-19 pandemic was hitting us. And we did use a rapid qualitative analysis approach. The purpose of using that is that actually PAHO in particular was very eager to know about feasibility and acceptability of these kits before the upcoming hurricane season, which was predicted to be one of the worst. I feel like we say that every year though, but predicted to be one of the worst at that time. And so with rapid qual analysis, it's really nice. You go in more deductively, right? You're looking really for feasibility, acceptability issues and challenges. And then we look at the themes that emerge, and these are some of those. So really the access to professional advice and medication was the main challenge to NCD management in the setting of a disaster. Again, the importance of mental health will not go away. The importance of addressing mental health and that acute distress in the setting of a disaster. I remember one person with diabetes who we interviewed after this more recently, actually, who said, how am I supposed to remember to take my insulin when I'm acutely traumatized in the setting of this? So how do we really overcome that so we can get them to manage their NCDs? The third theme was this lack of integration between NCDs and disaster response. Historically, whether you go to CDC's emergency response team or any of the emergency response teams, is very infectious disease focused, right? So it's all of those wash conditions. How do you keep people kind of water and sanitation, but not NCDs. So historically, NCDs in disaster have not been integrated, and that became very clear in these discussions. The next two were interesting. One, that COVID-19 really provided us with a unique opportunity to integrate NCD care into disaster response, right? The Build Back Better movement of NCDs, as we realized that the people hit the hardest by NCDs, by COVID-19, were individuals with chronic disease. But ultimately, there was a belief that the kits were acceptable and feasible, and really highly so. Interestingly, when we had our stakeholder engagement meeting, one of the biggest pushbacks was, are countries or islands in the region going to really pool money to purchase things in bulk and store them somewhere and then believe that they're going to be equitably distributed in the setting of a disaster? And of course, COVID-19 hit. And what did they all do? They pooled their money, bought kits and vaccines in bulk, and equitably distributed them to the islands. So really, it's because of COVID-19 that we saw that it could happen and it could be done. And I think prior to that, it was really interesting that our discussions were very much not in the same vein. And so we were presenting this to PAHO, and our partners, the Primary Care International, were part of this team when this happened. This is not a climate-induced disaster, but was an immense disaster for one of our partner islands, which were very involved in our stakeholder engagement activities. And of course, as this happened and their healthcare centers shut down throughout the north of the island, and they had over 20,000 refugees, they immediately said, we want the kits, right? I mean, you saw that they're feasible, you saw that they're acceptable, that's what we need right now. And so we mobilized very quickly with PAHO to get the kits on the ground. And we're doing a series of interviews and surveys now to really assess implementation of those kits. So hoping a follow-up presentation can report on those. There was a comprehensive report just published a couple of days ago by Primary Care International talking about their experience of virtual education, because again, it was still COVID, so we had to educate everybody on the use of those kits virtually, which hadn't been done previously. But it was really a really learning lesson of how feasibility and acceptability study really quickly transformed how we were able to manage NCDs in the setting of this disaster. And so that's a regional example. I will say the NCD kits now annually are housed in the Panama warehouse that PAHO has, ready for deployment. As the medication expires, they have a system by which those medication can be distributed as kind of free medication to sister islands. So moving now to an example of really health facility and individual level solutions for managing NCDs and disasters. And this is really what I spend the majority of my time doing, focused on really people living with NCDs themselves and strengthening their adaptive capacity. And so in the work that we've done in the US Virgin Islands of Puerto Rico, we've worked primarily with federally qualified health centers. So these are community health centers that serve the underserved, the uninsured, the underinsured, the high volume of migrant and refugee populations, and overall lower socioeconomic status. So we've worked with the only two FQHCs in the Virgin Islands, and then 20 FQHCs in Puerto Rico. And for this work and kind of thinking about institutional level and individual level adaptive capacity, we decided to use the EPIS framework. So this is exploration, preparation, implementation, and sustainment. We decided to use it because it was specifically developed to guide implementation of evidence-based programs in publicly funded settings. So it identifies those key inner and outer setting contextual factors that are important for us to consider during the implementation process. And so I'm going to show you a very messy diagram now, only to show you how it's possible to overlay your aims onto a framework. And so this is really how we thought about our aims as exploration, preparation, and implementation. And the aim two was really kind of bringing out how we can think about developing an emergency preparedness plan specific to NCDs. And aim one really was our exploration phase, trying to learn more about what was already on the ground. But again, mapping everything to what we know are those key determinants, those outer context, inner context, but also organizational factors. So thinking about aim one, which was our research objective, understanding the experiences of the FQHE as an organization, as well as their patients in addressing NCDs in the setting of recent climate-induced disasters. So we use a qualitative approach here of in-depth interviews, thinking very carefully about our axes of diversity and who we wanted to interview in this setting. The interviews were done mainly virtually over Zoom. The ones in Puerto Rico were done in Spanish and then translated. We have a wonderful community advisory board that helped us pilot the interview guide and refine it. We did do an inductive approach here. So this was a thematic content analysis with iterative coding, refinement of the code book, identifying the emergent themes. And then we took those themes and saw how they could potentially map onto the EPIS framework to help us again organize our thoughts around outer context, inner context, and organizational factors. And so these are some of the characteristics of the participants that we had, both from the provider side and the patient side. But let's look at some of the results which really are helping us feed into our system science approach, which we'll talk about next. So if we think about organizational characteristics and the themes that emerged related to that, not only was there well-organized leadership structure, that the organizational culture really prioritized the well-being of their employees. And I think this was wonderful to see, given the volume of providers and staff that they have. But at the same time, they realized their limitations and really had a willingness to learn and improve. At the individual level, there really was variable confidence in how well they felt prepared despite having experienced a recent disaster. And one thing that kept emerging was this double burden for providers, right? Having to deal with their own families and their own homes and their destruction, but still feeling compelled to come out and provide care to individuals and their patients. From an inter-organizational perspective, there really was a reliance on those ad hoc volunteers. This came out again, variable engagement with government operations, which, as we saw with FEMA's engagement, with the throwing of paper towels, with multiple things, it was very variable in multiple ways. The same with policies, which were very limited to allow access to medication in the setting of a disaster. And then from the patient perspective, again, those mental health challenges and really not having adequate services to address those acute challenges in order to overcome that distress. When we think about EPIS, the nice thing is it thinks about bridging factors, right? So you have organizational factors, patient characteristics, inner and outer factors, but then what's bringing it all together? And one of the themes that emerged that really spoke to this was this idea of working with the community for the community. I mean, these providers and staff knew the community, they were colleagues, they were friends, And I think that intimacy really allowed that sense of service that came out through a variety of quotes. So what we then did, so now that we kind of have a lay of how things are moving and how things are intersecting, well, what are the things that are good that we can leverage? And then what are the challenges that we need to address? And so that's how we organized these two. And this is really what was very helpful now feeding into our system science work. And out of those things that can be leveraged and things that can be challenges, there are those things that the FQHC has control over. And there are those things that we have to talk to policymakers and kind of at a larger picture start thinking about policy change to address them. And so as we talked in the system science approach, is really thinking more about the immediate things that we could address, those things that are in the hands of the FQHC and in the hands of the community. And so that really brings us to say we had a really good formative basis of what the challenges and the experiences were. And we now want to move into devising interventions, of finding approaches that can help us address some of these challenges. And for this, which is our second research objective, we turn to systems thinking. And why systems science? So system thinking is a way to describe and understand the causality and the interrelations between variables within a complex system. The dynamics part of things, when you think about people doing system dynamics, what they're doing there is they're now quantifying the impact of those interactions. And so there are people who just do it qualitatively, and then people who take the qualitative, put numbers on it, and make it into a dynamic model that you can then see the numbers associated with impact of interventions. But why participatory? And I think this is really where implementation science and system science cross over because of our belief in these participatory approaches and really understanding that these strategies are going to fail without a participatory approach and that we need to incorporate these structural and social determinants of health, addressing multiple levels in order for us to design effective interventions. And so the approach that we use is called participatory group model building. This is one of many methods in system science. The others that you might be familiar with are agent-based modeling and network analysis, ones that I'm not as familiar with, but do have colleagues here who use those approaches. Now, what group model building is, it's really a method for framing and understanding the challenges embedded within a complex system. It allows stakeholders to transform a mental model into an explicit causal diagram, looking at how factors are associated with a problem, there are consequences as a result of that problem, and then how everything is linked together. These are the iterative steps of participatory system dynamic modeling that you see here. When we do group model building, we don't do the steps after the simulation of the model. So what I'll be talking to you today about is creating the causal loop diagrams. I am talking to colleagues here who do simulation, who can hopefully then take this and try to make the dynamic part of it. So the one important thing with participatory group model building, as you can imagine, is that it's going to be a reflection of who's in the room. So how do we make sure that who is in the room is really reflecting the entirety of or as much as possible, the experiences of people and the important interested parties. So we work very closely with our community advisory board to think through the important individuals that needed to be part of this group model building process and invited individuals in Puerto Rico and the Virgin Islands to participate in these. So we had a total of 4 sessions, and we actually have a 5th one coming up this Thursday. So the sessions start with these, were initially all virtual because of COVID, and then the last couple of years we've been able to have some that are in person. I will say these methodologies have really been developed for in-person, but due to some of my other work that we've done, we've figured out ways of translating it into a virtual setting. So the first task is to define the problem of the number of people with poorly controlled chronic disease in the setting of a disaster. The number of people with poorly controlled chronic disease in the setting of a disaster goes up after a disaster. Our goal is to stop that number from going up. What are all of the causes that make that number go up? And what are all the consequences when that number goes up? And then how are all of those linked together? And those are really the steps that we took in these series of sessions. And this is an example of them listing out all of the causes, them listing out all of the consequences, and then we can only talk about so much in one session. And so we have to prioritize them and group them so that we can talk about them in sections. And this is what it looks like in a virtual setting. So this is the mess that you will see when you're doing participatory group model building. This program is called Vensim. And then you see people virtually joining us and chiming in. You still do want multiple facilitators in the room. You as the main facilitator are really focused on the Vensim, on the discussion, but you might lose track of, okay, who hasn't spoken for a while? You're gonna definitely lose track of time, so you need a timekeeper, and any kind of technical issues that your stakeholders might have. So I was grateful to have a few students who are helping me through this. So let me give you an example of how we kind of connect the dots. So this is persons with poorly controlled chronic disease after a disaster. You think about mental health problems. There's a plus sign here because mental health problems increase this number. If this number increases, then you have medical complications such as stroke. One of the many consequences of that is decreased productivity, which leads to negative financial consequences, which does what? Worsen your stress and anxiety. And so you have a reinforcing loop here that we have to figure out how to break when we start thinking about interventions. So this is one kind of basic example that was part of this, which is the end product, which is a much bigger causal loop diagram. And the goal here is not clearly to show the words, but really to depict the complexity and the intricacy of what can come out of these stakeholder engaged approaches. And honestly, when they see this model, they see this is their work, these are their words just put in a visual depiction, and they understand how things are so related and interacting. This is why it's a complex system. This is why when you think about an intervention, it's not just going to affect one thing, it's going to affect multiple things. And it allows us to be able to do that. So once we have this complex system, we can start thinking about these little arrows here, these little loops. These are the reinforcing and the balancing loops. These are areas where there are stories, right? There are stories around them. So mental health, again, clearly an area of focus. But we had other key ones. You can't quite see that, but that's homelessness. Key factor that kept kind of being connected to multiple things. The awareness of your chronic condition and how to self-manage that chronic condition. Food insecurity also came out as a huge factor, all related to these loops that we are seeing come through. And then this last one was the lack of medication. So what we then can do is take those loops and develop stories. And these stories are really the main messages that are coming out of this causal loop diagram that can then become our foci for interventions. So I'll just read through some of these stories. Again, the important role of mental health, food insecurity, housing insecurity, the lack of providers, access to medication, social and community support, awareness of the role of NCDs in disasters. Again, what's nice is the triangulation here between the scoping review, the qualitative work, and now the system dynamic modeling, really pointing to the same kind of issues coming out. But what's key here is now they're looking at interventions. They're now looking at the factors that cause these stories, that contribute to these stories, and now can start to identify interventions and ways of addressing them, which is what we then did and are continuing to do. We're not finished. We have a few more stories to tackle on Thursday. So some of the strategies that emerged from this is how do we improve the ability to self-manage disease? And we talked a lot about potential interventions for that. Institutional level, how do we strengthen the ability of providers to educate their patients, but also provide that mental health and acute distress management? At a system level, how do we get a reimbursement for medication early on? And how do we ensure access to healthy food and a safe shelter? And so how do we now talk to them, focusing on these things, about strategies that can address these issues? So this is one example of material that we developed as a result of this to really help providers talk to their patients about climate-induced disasters and their impact on their health, specific to their chronic disease. We were able to translate this into Spanish and Haitian Creole. There's a huge Haitian population in both the Virgin Islands and Puerto Rico. But what we also realize is for some of these, again, there are some things that we could turn to evidence-based strategies to address, right? So the mental health and psychosocial support, there are multiple community health worker as well as layperson psychosocial interventions that are out there, either led by the WHO, such as PM+, MHPSS, that we can now perhaps adapt to the context of these disasters and address this challenge. The pharmacist-led prescription refill programs have been used in multiple settings for other situations, but not in disasters. So how can we then adapt that same intervention to a disaster context? So these are now 2 grants that are under review as a result of this to hopefully be able to address some of these challenges. And so, as I mentioned, though, this is not unique to the Caribbean. You saw the map. There are many other parts of the world that are experiencing the same challenges. And so we've now really thought about how we can translate this work into Mozambique, which is another part of the world that unfortunately is repeatedly hit by cyclones. And really working with their Instituto Nacional de Saúde, which is their institute, their National Health Institute, to think about how we use a very similar approach to try to address challenges. So we've only finished the formative work here with in-depth interviews with patients and providers and health service personnel, mainly in Beira, which was part of Mozambique that was most hit by Idai, by Hurricane Idai in 2019, and now, unfortunately, more recently, just in 2023. But you'll see that we have the same issues kind of emerge again, exactly the same themes that we saw come from the Caribbean. So access to medication, importance of self-management, health service delivery disruption, and the importance of these coordinated multi-system efforts. And so in summary, hopefully, leaving time, yes, about 15 minutes for discussion, but I hope that I've conveyed that climate change and climate-induced severe weather events will worsen global health equity. Climate change vulnerability is a function of exposure, sensitivity, and adaptive capacity, that individuals with NCDs are among the most vulnerable to the impacts of climate change, and that we really need those innovative approaches to strengthen the adaptive capacity of at-risk populations, and that implementation science and these participatory approaches are really critical to identify effective and sustainable interventions at all levels. And really a call to action, hopefully, for all of you here that, especially if you're doing global health, regardless if it's NCDs or infectious diseases, there are many ways in which climate change, I'm sure, is impacting your work, and we need to really do a more multidisciplinary coordinated approach to be able to address it. And so with that, I'll thank you, and thanking, of course, my team. Thank you so much.
It was great. Thank you so much. So yeah, we have time now for questions. I didn't see any come up in the chat yet, but oh, see, William, you have your hand up.
Yeah, thank you. Thanks for a great presentation. I'm here in Houston, and we've had our own share of natural disasters and flooding disasters, and most recently Hurricane Harvey that I've done a lot of work with, and we passed out kits after Hurricane Harvey, and one of the things that really made an impression on me was the variety of different distribution systems that handed out relief, and how throughout this ordeal right after Harvey, I didn't see interact at all with FEMA. It was with church organizations. It was with just different non-for-profit organizations that set up these just almost sort of spontaneously assembled throughout the city. And so I would think that since you're working with different countries, different islands, that each one of these has their own unique distribution systems. And I wondered, in your experience, if you can see as you're developing these systems the need for flexibility according to each individual country or part of the country's way of distributing supplies, and how you might kind of address that so that it's applicable to other areas.
Yeah, I think you kind of hone in on what is actually a challenge. So I don't think, I think the one commonality across all of them is that there are these ad hoc, spontaneous setups of relief. And that is a common thread throughout. And so they saw it in the Virgin Islands and in Puerto Rico for sure. And in the Bahamas, we have one quote where one was saying, we just get all this stuff, and some of it is unwanted. And so, how it's going to be more effective if there is better coordination to make sure that the most vulnerable have access. And so I will say that I don't think there's a system where we can have lessons to learn from it, unfortunately, not yet, at least. But there is that for sure underlying thread of these pop-up ad hoc. If you hear about it, great, then you know where to go. If you don't, then you're out of your meds for a long time. So how do we stop that and make sure that everyone is able to have access to these key resources in the setting of a disaster? I will say that the Bahamas in particular, with Hurricane Dorian, they really struggled with the amount of relief, unsolicited relief that was coming in, and really hampering their own efforts on the ground from a government side. And we have that on some of our interviews from the Bahamas that we actually did last summer and this past summer. So that work was not included here. And they're really now thinking, they have now a new climate initiative and thinking about how to better coordinate efforts for the government, so that this external help comes solicited and organized in a way that can be funneled for effective relief. So hopefully maybe that'll become a system that we can learn from. And so hopefully we'll be able to follow up with the Ministry of Health and learn more about that. So thanks for the question.
Yeah.
Maria, you have a question.
Hi, thank you for a fantastic presentation. So I was really interested in sort of the mechanism mapping and using the those diagrams with the community, right? So I've been involved in some efforts around how you can use these diagrams to understand mechanisms. I just added something to the chat there, but I was curious about communicating that with the community, and how was that challenging? What other tools did you use to talk about the different the relationships and the feedback loops, and just curious about if you experienced any challenges and how you got around that, because I've seen it. I haven't really seen it used exactly in that context, and I think it's really interesting. But I also wonder, with some groups, whether or not they'd be able to really understand it clearly.
Yeah, I mean, we do spend a lot of time in that first session really thinking about relationships and positives and minuses. And we use a very basic model of birth, population, and death, understanding that more birth gives more population. More population means that there are more deaths. But if you have more deaths, there's less population, and how that loops back. And so that's the basic model we use to explain the example of these causal loops. But they get it. I mean, I'm using the same approach now in the southwest of Atlanta, which has overall a lower educational level than the individuals we were working with in the Virgin Islands and Puerto Rico. We're doing it around climate impact on mental health. And, we have the most intricate mental health map now of how climate change is impacting their mental health. So again, once you kind of really do the basics of what an arrow means, and what even the plus and the minus means. Is it making the number go up, or is it making the number go down? And then once they start to even see the loops, they're like, oh, but that loops back to that. Doesn't that touch that issue as well? It's quite a dynamic conversation. And it is challenging to get them to get it the first time, but once it clicks, and it clicks for pretty much everyone, then they're rushing to say plus or minus. And I'll say, this arrow links here. Okay, is it a positive or a negative? And some people will shout out positive. And no, that's a negative. How is it a positive? And it just is a way for them all to get engaged in the discussion. So it really is a dynamic way of engagement. But I found that most people get it.
Thank you.
Thanks for the question.
And I just wanted to let you know, in case you didn't. So I've been involved in a U54 with with MD Anderson with Puerto Rico, University of Puerto Rico, for many years. And so there was a group that including Ana Patricia Ortiz and others, who published a series of papers after Maria around similar types of issues in cancer control specifically. And then also when we were right in the middle of a group randomized trial with the FQHCs in Puerto Rico on colorectal cancer screening when these hurricanes hit. And so it was really, really interesting to see kind of not just what happened in terms of patient care and treatment and things like that, but then also in research. And it was pretty remarkable, I thought, given the challenges, like how quickly things kind of got up and running in certain areas, even though there was really difficult situations continuing, to be sure. But I think that this is a really nice application that you've done from an implementation science perspective that that I think that there can be a lot of applications for. So thank you so much.
Oh, thank you. And it's okay. I'll reach out to you afterwards for more conversation. I don't know if this is the same group with Vivian Colon Lopez. Yes. Okay, great. So we do have at least some familiarity with folks.
Yes.
So no, thank you so much for that comment.
Yeah, we're co-leaders on the community outreach core.
Okay, awesome. All right.
Yeah, Amber.
Hi, Dr. Hassan. This is really, my name is Amber. I'm from University of Texas Health Sciences Center. I'm with the Institute for Implementation Science, core faculty here. A fantastic talk. It was really, really great. And I really, really love the community-based focus of, kind of devising and figuring out solutions to actual on-the-ground problems as they occur in a disaster. But as I was thinking, especially through your last few slides, when you're thinking about some of the strategies you might use as solutions, those have to exist, and correct me if I'm wrong, but I just assumed that they would have to exist beyond disasters, meaning preparedness for disasters. So I was kind of wondering, and I feel like this is a global health question I ask everywhere, which is, how do you find ways of fitting that within priorities or existing priorities or priorities that exist before you even got there, from low and middle income settings where disasters are just a piece of a much, much larger health puzzle. And just what have your experiences been with that, especially thinking about the outer setting and some of those bigger things that maybe those health systems or organizations or communities can't necessarily address, and what are the things or ideas or strategies that you've been trying to leverage in terms of priority?
Great, thanks. Initially, I thought your question was going somewhere else, which is where I will address my other thought as well. But to that, I think it depends where you're working. So I will say in the settings where I'm working now in the Caribbean and in Mozambique, disaster preparedness is absolutely a priority. I mean, these countries have been hit repeatedly, and the impact on the population and on the little health services that were there is profound. And so you'll notice even in our stakeholder engagement here, Ministry of Health was at the table throughout in the Caribbean. And now in Mozambique with the Instituto Nacional de Salud, they have direct access to the Ministry of Health because they're under the Ministry of Health. And so they are able to attend our stakeholder meetings, and we were able to conduct interviews with them. So I do think that's going to start to shift. Because you can't rebuild the same system every time that's going to just succumb to disasters. I mean, it's now become so cyclical. Mozambique is a perfect example of that, where it's 1 year after the next, after the next. And so as soon as you're trying to emerge from something, you get hit again. And so we really have to develop a way to strengthen the resilience of those systems and of individuals themselves. Otherwise, the problem is just going to be a down spiral as opposed to just the stagnation that many of these countries have had. So I do think it depends where you're working. So for sure, in countries that haven't experienced this and it's a once every 10-year event, it is going to be harder to push it to the top of the agenda. But I have a feeling it's going to start to shift very quickly as people start to realize the impact of climate change overall. Where I thought you were going was, how do you measure the impacts of this, right? Are you going to have to wait for a disaster to happen to say that, oh yeah, look, we actually did better after a disaster? And that is something I'm struggling with and have struggled with as I write grants. And so I think one of our ways to address that is to be able to better measure adaptive capacity, because that can be our proxy. So if we can strengthen adaptive capacity and a good way of measuring it, we could then perhaps be able to say how interventions are successful. But thank you for the question. It's very important.
Go ahead, Cheryl.
Thanks. I just wanted to go ahead and say thank you so much. And this is really important and rewarding to hear so much about this great work. I wanted to ask you a little bit, you talked a lot about mental health, and I'm thinking about the situation, especially in Mozambique, where there's probably hardly any, help in terms of mental health, and the capacity is so limited and the need is so great. And I was just curious, in terms of disaster research, how are people sort of trying to address that, especially when you have a community advisory board and it's so incredibly stigmatized. So I was just wondering if there's any evidence-based practices that you guys have seen that really work in those sort of situations.
So I'm working very closely now with partners in psychiatry and psychology, because again, I'm new to this field, but not really. So not really in the acute disaster setting. So in humanitarian longer term emergencies, MHPSS from the WHO has shown great impact and results, as well as PM Plus as another intervention where you can train lay persons to really deliver those interventions. So you don't have to rely on mental health experts, which are with limited access. So absolutely. So in Mozambique, we actually wrote a grant to Great Grand Challenges that didn't get funded, but really trying to kind of, again, leverage that idea of we don't really want to improve mental health outcomes, right? So it's not really like they have depression. It's like there is an acute distress that happens that we need to be able to manage for people to survive. How do we help people manage that acute distress? And I think that's what hasn't been studied, at least in the acute disaster setting. We know the impacts on people with existing mental health disorders. We know the impact from a PTSD trauma perspective, but that acute distress and how to overcome it is really, I think, where we're turning to, at least in my lab, to think about, and really adapting PM Plus and MHPSS and skills for psychological recovery. There are a bunch of interventions that have shown to be effective in other contexts that we just need to bring into here. I will say there are groups in Puerto Rico that went out after Maria giving psychological first aid training, which was found to be extremely helpful to those communities after the fact. Our goal is to be able to train individuals beforehand, so they're already trained to reduce the amount of trauma when the experience actually happens. But thankfully, to those teams who I do partner with, we do have some experience of delivering these interventions after a disaster.
Great, thank you.
And then Saswati and I think that'll probably just about do it for us. Unfortunately, I feel like we could talk forever on this.
Thank you. Hi, Dr. Hassan. Thank you for such a great presentation. I just wanted to say I'm really interested in climate change and working on the injustice part of it. So just curious, from your experience working on the focus groups, what is the physician buy-in to these projects? Like, coming from a developing country where I have been a physician, I know that climate change is something that's not really talked about on a day-to-day scale, but there's always that apprehension of the physician buy-in, because they are also important stakeholders in this. So what was your experience with that and your perspective on it?
Yeah, absolutely. Very, very important. Again, I'm biased in some way because I work in contexts where physicians were directly impacted by these storms. But even that being said, when we surveyed physicians in these FQHCs, 70% of the providers who are providing direct care never counseled their patients on disaster preparedness. So, clearly there's still a gap because, that we do need to still fill. And we are now really doing a series of webinars around climate and climate-induced disasters for the faculty that are part of this FQHC. In Mozambique, it is more of a challenge, because again, it's just busy lives and busy day to day. But they are an important stakeholder because they deliver access to medication, but they're not the solution per se, right? So I think that a lot of the solutions that are coming out of these diagrams are more individual based or community based. Really, the physician's role is more of that educating the patient with NCDs, but not necessarily where interventions themselves will be. At least that's what's coming out from the data we have here. But yeah, there's still I think it will again shift as more of these heat waves come, as we're seeing more of these exacerbations due to extreme heat, due to extreme cold. The mentality will start to shift, but it's already too late, and we just need to do more. Thank you.
Thank you.
Well, we're after the hour, so I'm going to go ahead and just thank Dr. Hassan so much for this talk. It was really thought-provoking, and like I said, I'm probably going to ping you later on with some of my own questions and interests. But yeah, thank you for sharing this with us, and we hope to see everybody at, we'll send out an announcement about the next GIST talk later on this year. So
Great. Thank you, everyone. Thanks for the great questions.
yeah,
Bye.
take care.